Welcome to the Healthcare and the ADA Inclusion of Persons with Disabilities webinar series. I'm Louis Krause from the Pacific ADA Center, your moderator for this series. This series of webinars is brought to you by the Pacific ADA Center on behalf of the ADA National Network. The ADA National Network is made up of 10 regional centers that are federally funded to provide training, technical assistance, and other information as needed on the Americans with Disabilities Act. You can reach your regional ADA center by dialing 1-800-949-4232. Real-time captioning is provided for this webinar. The caption screen can be accessed by choosing the CC icon in the meeting control toolbar at the bottom of your screen. To toggle that meeting control toolbar permanently on, press the Alt key once and then press it a second time. As always in our session, only the speakers will have audio. The audio for today's webinar is being broadcast through your computer. Make sure your speakers are turned on, your headphones plugged in. You can adjust the sound by navigating to the audio settings on the bottom panel. You can adjust the sound by sliding the soundbar left or right in the audio tab. If you do not have sound capabilities on your phone, on your computer, or prefer to listen by phone, you can dial 1-669-900-9128 or 1-646-558-8656. And you can use that webinar ID that's on the screen, 760-897-977. And I want to note for everybody that the webinar is being recorded and can be accessed on the adapresentations.org website in the archive section of the healthcare section next week. This webinar series is intended to share issues and promising practices in healthcare accessibility for people with disabilities. The series topics cover physical accessibility, effective communication, and reasonable modification of policy issues under the Americans with Disabilities Act of 1990, the ADA. Upcoming sessions are available at adapresentations.org under the Schedule tab, then follow to Healthcare. These monthly webinars occur on the fourth Thursday of the month at 2:30 Eastern, 1:30 Central, 12:30 Mountain, and 11:30 a.m. Pacific time. By being here, you are on the list to receive notices for future webinars in this series. Those notices go out 2 weeks before the next webinar and open that webinar to registration. You can follow along on the webinar platform with the slides. If you are not using the webinar platform, you can download a copy of today's PowerPoint presentation at the Healthcare Schedule webpage at adapresentations.org. At the conclusion of today's presentation, there will be an opportunity for everyone to ask questions. You may submit your questions using the chat area within the webinar platform, and the speakers and I will address them at the end of the session, so feel free to submit them as they come to your mind during the presentation. To submit those questions, you type them into the chat text box area, or if you are using keystrokes, press Alt-H and enter your text in the chat area. If you are listening by phone and not logged into the webinar, you may ask your questions by emailing them to adaTech@adapacific.org. That's ADATECH@adapacific.org. If you have any technical difficulties during the webinar, you can send a private chat message to Pacific ADA Center, the host, by typing that in the chat window and type your comment in the text box and enter. Again, if you're using the keyboards, you can do that by doing Alt-H to access that chat box. You can also email any technical assistance issues to adatech@adapacific.org, or you can call us at 510-285-5600. Today's ADA National Network Learning Session is titled The Geographic Distribution of Accessible Medicaid Participating Primary Care Offices in Los Angeles County. This webinar will present the findings from a study that examined the geographic distribution of these accessible Medicaid participating primary care offices in LA County, and will describe a methodology for collecting and utilizing data on office accessibility that has been implemented with thousands of primary care offices in California. This analysis makes it possible to illustrate equipment and geographic barriers that affect equitable access to health care for people with disabilities. Today's speakers are Mary Lou Breslin. Mary Lou is a senior analyst with the Disability Rights Education and Defense Fund, DREDF, a leading national civil rights law and policy center. Her current work focuses on the organization's healthcare, long-term services and supports, and home and community-based services research initiatives. Nancy Mudrick is a professor in the School of Social Work at Syracuse University. Dr. Mudrick's teaching, research, and publications focus on understanding the impact of social policies. Her recent research in partnership with Mary Lou and DREDF addresses issues affecting the delivery of accessible and equitable healthcare to people with disabilities. Kieran Nielsen is a research assistant at Syracuse University and working alongside Nancy and Mary Lou. Kieran has been involved in research projects on the issues that people with disabilities face in accessing healthcare. So I am now going to turn it over to you, Mary Lou, Nancy, Kieran, here you go.
Great. Well, thank you very much, Louis. Hi, everybody. This is Mary Lou. Can we see the next slide, please? So before we begin, we would really very much like to extend a special thank you to the organizations that have thought the work that we've been doing looking at accessible facilities in California is as important as we do, and who have supported it. And that includes the Pacific ADA Center, the WITH Foundation, and the True North Foundation. And we specifically want to acknowledge and send out a big thank you to June Kales and Brenda Primo, whose work began with California Medicaid managed care plans over a decade ago, and that work continues today. And it was really instrumental in the development of the data collection process and the data that we present in this webinar today. So thank you very much both to June and to Brenda. And June, if you're listening today, we are very grateful for all the work that you've done. Next slide, please. So the webinar we'll be presenting today will be in 3 parts. In part 1, we plan to discuss why accessibility and geographic location matters for people with disabilities who need healthcare from primary care providers. We'll also review research and data documenting access barriers and describe briefly legal requirements for healthcare setting access. In part 2, we will be describing what we think is a feasible method for measuring primary care office accessibility across a geographic region, and present a survey tool based on the ADA architectural standards to assess accessibility. We're also really excited to introduce how geographic and census data can be used to evaluate the match of accessible provider offices to a number of potential users. And finally, in part 2, we will be presenting an example of data analysis that combines access characteristics and geographic location. In part 3, we're going to be talking about how some federal agencies are recognizing the importance of and need for measuring provider accessibility and some potential policy and advocacy opportunities. Next slide, please. So our learning objectives today include an understanding of the potential impact of the geographic distribution of accessible doctors' offices on healthcare for people with disabilities, and a knowledge of a viable method for measuring primary care office accessibility. So with that, I'd like to just turn the presentation over to Dr. Mudrick.
All right, hello, the next slide, please. All right, so this is part one. In this portion of the webinar, we want to set the frame by briefly explaining why learning about the state of provider facility access is necessary. The reasons follow these three bullets: why accessibility and geographic location matter, what the research to date on access barriers tells us and does not tell us, and the legal and regulatory reasons for conducting analyses of facility accessibility. So next slide, please. So why does accessibility and geographic location matter? For accessibility, health disparities are connected to access barriers. A number of studies document disparities in healthcare treatment and utilization rates comparing people with and without disabilities. For example, adults with disabilities are 2.5 times more likely to report skipping or delaying health care due to cost, and they are significantly less likely to receive some preventive care testing, such as mammography and Pap tests. People with disabilities report how physical access barriers delayed their treatment or resulted in less than optimal treatment. Geography matters because access is not equal if there are few choices. How far should a patient expect to have to travel for primary care? Most people choose a primary care provider, thinking about that provider's proximity to their residence or their work. They select physicians whose style is a good fit for them, maybe in philosophy or use of medication or interpersonal style or reputation. So geography is connected to having equal opportunity to receive care from one's preferred provider. Geography also offers a metric for seeing where equal access does not really exist, whereas statistics aggregated over a state or a region can mislead. Next slide, please. The next slide. Oh, thank you. Facility access is important because patients report experiences of inferior care or refusals to be accepted as a patient due to inaccessible primary care offices. The 2013 publication by Lagou et al. Reports that 44% of specialty physician offices called to take a referral of a patient with a mobility impairment refused the referral due to lack of access of their building, their offices, or their equipment. Access barriers are also well documented in surveys and focus groups with people with disabilities. This 5-minute video that we're going to show right now contains excerpts from a large set of interviews conducted by DREDF in which people speak about their healthcare access and healthcare treatment experiences. Can you start the video now? Thank you.
DREDF, Healthcare Stories.
Part 1, Tables and Scales.
My name is Alice Wong, and I live in San Francisco. There's one area that I'm very bad about are getting routine public exams. So this is a women's health practice, and they do not have a single adjustable height exam table. I'm not getting regular public exams because of this hassle.
My name's Larry Voss. I live in Darien, Illinois, suburb of Chicago. I had a lot of discomfort in my abdomen. It was diagnosed originally as a bowel obstruction, and it was recommended by him that I have an MRI. But when I went there, we found out that there was no way that physically they could get me as a wheelchair user and a vent user onto the exam table that they used for the MRI, and they didn't have Hoyer lift or any kind of other ways of giving me access to that equipment. So finally, we did get a call from the nurse that she had found an accessible facility. This took about 9 months in total. And when the scan was done, the MRI was done, they found that what had originally been a much smaller growth that they detected had become almost double the size.
My name is Frances DeWoach. My doctor's office, unfortunately, is not that wheelchair accessible. The exam tables, forget it. I have to literally be picked up to put me either on the table or off the table. I need the examining tables in order for me to transfer and now myself. I need them to be able to move up and down so I can do what I call a slide transfer, which is basically transfer on my bottom from one surface to the other. If they go and pick me up to put me on an exam table, and if they don't do it right or listen to me so I can tell them how to do it, I will end up breaking a bone.
My name is Michael Ogg. I live here in Princeton Junction, New Jersey. Just before I was hospitalized at the doctor who examined me and then sent me to hospital, again in his doctor's office, he had an examination table, but no transfer equipment. He worked single-handedly. Actually, the first time I saw him, he got his secretary to help transfer me. Generally, secretaries don't like having to lift people. It's not their job, and they shouldn't be doing that, and they're certainly not trained to do it. I don't think I've been to any single doctor's office where they've actually had transfer equipment.
My name is Jennifer Thomas. I'm 35 years old. I live in Arlington Heights. When I was 9 months pregnant and had to go for one of my last ultrasounds, there was no accessible table. Really can barely get up to the desk to check in, and somebody says, oh, and really sort of dumbfounded, like, how are we gonna treat her? And, you know, wow, like a person with a disability getting pregnant was some kind of science experiment. And it's not.
My name is Mary Delgado, and I live here in Chicago. I went 5 years without a pap smear because I could no longer get up on the table. So I told my doctor I need a pap smear. She said, oh, you know, you do need a pap smear. And then she said, I need one where the table's low so I can scoot over there. She said, that's a great idea. Find one. I have to always guess at my weight. I've not been weighed, let's say, for 20 years.
I have frequent visits to a doctor's office, neurologist, physiatrist, urologist, you name it, primary care, you name it. I see quite a few doctors, and not one of them has a way of weighing me. The last time I was weighed in a doctor's office was when I could last stand on my own 2 feet, which was well over 10 years ago.
I think if you ask any person with a disability, these issues are part and parcel with everyday experiences.
Healthcare stories.
All right, thank you. The next slide, please. So these testimonies, I think, are very eloquent and really set up the case for why we also need to look at this in a more formal way. So another reason why we should monitor healthcare setting access is that Titles 2 and 3 of the ADA apply to medical care providers, something I'm sure this audience is well aware of. This means that providers have an obligation to enable full and equal access to healthcare services and facilities and make reasonable modifications to policies, practices, and procedures when necessary to make healthcare services fully available to individuals with disabilities, unless those modifications would fundamentally alter the nature of the services. Next slide, please. This slide expands upon why measuring physical access matters for Medicaid managed care plans by linking the ADA to Medicaid managed care federal requirements and sets the stage for the data and methodology and analysis involving managed care plan providers that we will present in part 2. Title II covers a public entity that provides aid, benefit, or service directly or through contracting or other arrangements. Medicaid managed care plans have obligations in how they deliver healthcare services as contractors under state Medicaid programs. Title III applies to private doctors' offices as public accommodations. Even a practice not on a Medicaid managed care panel must remove architectural and communication barriers to equal access when removal is readily achievable. And finally, in regulations for Medicaid managed care, the Centers for Medicare and Medicaid Services set out access requirements. States receiving Medicaid funding and distributing it to their managed care plans must assure CMS that the plan's network provider offices and facilities are adequate to serve the target population and that they are accessible. This requirement has existed in a general form for a number of years. Later in this webinar, Lou Breslin will talk about the access requirements of the most recent version of the regulation. So the next slide, please. Documenting primary care office accessibility is important, but it does not happen routinely due to a number of challenges. Here are 5 challenges to collecting access data. First, there is no national database. No single survey is conducted in every state and centrally collated. Thus, we do not know the state of access nationally. In smaller regions, we don't know if every person with a disability sees the same 1 or 2 doctors, or whether there is a wide choice of accessible providers. Second, to date, where there have been surveys of provider office access, the sample sizes have been small, generally in the hundreds, and maybe even less. Some surveys have used self-reports, a problem because observed access is generally lower when compared to what was self-reported. Surveys that solicited respondents may also have response bias, since those confident about their accessibility may be more likely to respond. A third challenge involves who will conduct the access audit. In addition to provider self-audit, audit forms have been offered to patients to conduct the assessment when they visit their doctor's office. This puts a burden on people with disabilities and may create awkwardness between the patient and provider. This fourth challenge involves a provision in the Affordable Care Act that was promising but was never implemented. Section 4302 of the Affordable Care Act required the Department of Health and Human Services to survey healthcare providers and establish other procedures in order to assess access to care and treatment for individuals with disabilities. And included in that was they were supposed to be able to identify locations where individuals with disabilities access their primary and acute care and long-term care, the number of providers with accessible facilities and equipment, and the number of employees of healthcare providers trained in disability and patient care of individuals with disabilities. No work was done to develop the mechanisms to do this, and this section of the Affordable Care Act has now sunsetted. A final challenge involves the implementation of the 2016 Medicaid managed care regulations, which were issued but have not been implemented, and Mary Lou will say more about this. So now we'll move on to part 2. Next slide, please. So with the prior frame, in this part of the webinar, we will describe a method for assessing primary care office accessibility that's used in California, and then we'll describe our work that combines the office accessibility information with geographic and census data, and we will show you the product of these 3 different data sets as an example for Los Angeles County. Next slide, please. In California, Medicaid managed care plans have been conducting on-site walkthrough audits of primary care office accessibility since 2006. The accessibility audits began as a voluntary add-on to an on-site audit mandated by the California Department of Healthcare Services. Today, this add-on is part of the site audit. The basic audit asks for things like access and safety, personnel, qualifications, office management, clinical services, preventive services, and infection control procedures. Starting in 2000, a small number of the California Medicaid managed care plans worked with June Kales and Brenda Primo to design an accessibility assessment tool to be used at the same time as this mandated audit. The procedure for the audit requires that a trained reviewer walk through the primary care office to complete the full audit. The audits are conducted when the primary care practice joins a plan and every 3 years after that. Each managed care plan holds onto the data they collect, but the plans share the data so that a single practice that's associated with more than one plan is reviewed only once in the cycle. What's important about this process is that it's mandated. Practices don't have the option to volunteer or to opt out. Next slide, please. The audit tool is titled Provider Facility Site Review Accessibility Tool for Seniors and Persons with Disabilities. The 2012 version, which is what we used, has 86 questions in total. Of these, 80 questions involve physical accessibility, and the items are derived from the 2010 ADAG guidelines, accessibility guidelines. 6 questions ask about equipment. The auditor walks through the site, observes characteristics like door handles and lighting, and also takes measurements such as door width and weight, turning radius, ramp angles, and so forth. Because California now requires the assessment for everybody, more than just the original 4 plans are conducting these assessments. Next slide, please. This slide shows, so it summarizes the elements in the audit tool in major categories. And on the right-hand column, we have the number of elements looked at for each category. So the first category is parking with 13 elements, and they include such things as accessible space and signage. The second category is exterior route from parking, transport, or sidewalk to the front door with 10 elements, and they are things like surface quality, ramps, and curbs. Third, building entrance includes door width and swing and signage, and there are 8 elements in total there. Fourth, interior route and in office interior, and that's 20 elements that look at the path of travel and floor surfaces, lighting, and stairs if there are any, and their characteristics. There's a section devoted to elevators if there is an elevator, and there's 10 elements there, including looking at the call buttons, the signage, the turning radius, and so forth. 18 elements around toilet rooms with and without stalls are examined, and that includes turning radius and such things as the location of the grab bars and the faucets and doorway. Finally, there are 7 items that address examination rooms and examination equipment. 6 are the equipment questions about height adjustable exam tables, scales, and patient lifts, and 1 question about the exam room itself. Next slide, please. This slide is a screenshot of 1 page of the audit tool, and it is a page in which the space around the sink is being assessed, and you can see that the graphic puts out what the measurements are that the auditor needs to measure and to check that there's sufficient size around the sink. This page also asks for about the faucet handles and the protective covering on the pipes. Next slide, please. And this is another screenshot of the audit tool, and this is the page that asks about the presence of a height adjustable exam table and also marks out the space that's needed next to a table for someone in a scooter or wheelchair and to have enough space to park and transfer. So the auditor would be measuring for these dimensions. All right, next slide, please. So now that I've explained the data source, we'd like to show you some examples so you can see what's possible to learn from this. In 2017, Lou Breslin and I contacted the people in the Medicaid managed care plans who were responsible for the accessibility review and asked if they would send us their data for 2013 to 2016. We received data from 5 Medicaid managed care plans for a merged data set of 3,993 primary care practices. Plans sent only access data plus city, county, and zip codes of the practice, but we don't have addresses or any other identifying information for the practice. We believe this data set could be the largest, or maybe the second, one of two large data sets across the nation that have on-site review of doctor office accessibility. However, not every California Medicaid managed care plan sent us data, so the statewide coverage of the 3,900 offices is uneven across the state. However, the two plans that serve LA County did send their data to us, and for that reason, we focused this analysis on the 2,096 practices in LA County. The next slide shows some summary data on interior office elements and equipment from the data set. Next slide, please. The top half of the table lists across the county the presence of equipment and accessible toilet rooms for those 2,096 practices. 14.9% have height adjustable exam tables, 8.6% have accessible scales, and 3.7% have patient lifts. 49% of the bathrooms have between 70 and 100% of the different access elements that were rated for toilet rooms. These numbers are not large, but for context, the exam table and scale numbers are about twice as large as what we found in a 2006-2009 analysis of similar statewide data for California. At that time, it was 8.4% for tables and 3.6% for scales in terms of being present in provider offices. The lower half of this slide uses the zip code information for a geographic look. And from this, we can see that 47% of the LA zip codes contain at least one practice with at least one height adjustable exam table. 31% of zip codes have at least one practice with an accessible scale, and just shy of 16% have a practice with a patient lift. 26.6% have bathrooms with many of the accessibility features. Even with these numbers, though, we do not know whether the 47% of zip codes with an accessible exam table are all bunched together or whether they are evenly spread out through the county. For that, we need to be able to map them. And so I'll now turn this discussion to Kyria Nielsen, who will show you some maps and explain how she did it. All right.
Thank you, Dr. Mudrick. All right, could you move to the next slide, please? All right, so this slide is just laying out the methods that we used in creating the maps of accessible Medicaid participating primary care offices in LA County. As Dr. Mudrick mentioned, we were curious to see the geographic distribution of accessible exam equipment, and we wanted to know whether there was a goodness of fit between the presence of practices with accessible equipment and the people who might actually need this equipment. In doing so, we used ArcGIS mapping software to create a geographic representation of this distribution. We used an ArcGIS base map of Los Angeles County and overlaid the information from the audit tool that Dr. Mudrick talked about earlier to display the number of medical practices within that zip code that contain accessible medical equipment. We created 3 separate maps, each of them displaying a different type of accessible equipment, either accessible exam tables, accessible scales, or patient lifts. In order to determine if there was a relationship between the presence of disability accessible equipment and the presence of people with mobility impairments, we downloaded data from the American Community Survey reporting the number of people with a mobility impairment by zip code. We downloaded the 2016 data to match the data that we had from the audit tool, and we did this by zip code because we had the audit tool data by zip code. We then grouped the number of people reporting a mobility impairment into 3 separate categories, from 0 to 2,000, 2001 to 4,000 people, and 4,000 and above. In order to put this on the map, we color-coded these 3 categories, with yellow indicating that a zip code contains between 0 and 2,000 people with a mobility impairment, orange indicating that between 2001 and 4,000 people reported a mobility impairment, and red indicating that 4,000 or more people reported having a mobility impairment within that zip code. And lastly, we overlaid a 10 square mile grid to provide context to the map, indicating the distance that people might have to travel in order to find a practice that contains certain accessible equipment. You can go to the next slide, please. So on this slide is the first of the 3 maps. This one is displaying the number of practices per zip code that contain a height adjustable exam table. In looking at this map of Los Angeles County, the map is boundaried by zip code, and each zip code is colored according to colored using one of the three colors mentioned previously, either yellow, orange, or red, depending on the population density of people reporting a mobility impairment. To add some numbers to what you're seeing, 57% of the zip codes are yellow, which again indicates that a population density of people with mobility impairments ranges from 0 to 2,000. 32% of the zip codes are orange, which is the 2001 to 4,000 range. And 6% of the zip codes are colored red, which indicates that there are more than 4,000 people in that zip code that report a mobility impairment. It can be seen that there are a few zip codes on this map that are colored gray. This reason being is that we didn't have population data for those zip codes. In each zip code, there's a black circle with a number in it, and this number indicates the number of primary care practices within that zip code that contain a height adjustable exam table. So this is not the number of exam tables in that zip code, it's the number of practices that have an exam table. The numbers of practices with exam tables for this map ranges from 1 to 10, with most of the circles containing either a 0 or a 1. This means that for the majority of the zip codes, there is either no practices or one practice with a height adjustable exam table. There are actually 230 of the 233 zip codes that we have data for. 88 of those zip codes report having 0 practices with exam tables. And there's only one zip code that has 10 practices with exam tables, and this zip code is over on the southeastern portion of the map. It can be seen that there are a few zip codes without a black circle, and again, this is because we were not given equipment data for that particular zip code. It can be noticed that the zip codes are much more spread out in the northern portion of the county, and that they're much smaller and squished together in the southern region. This is due to the population density of LA County, because the majority of the population lives in the southern portion. So the zip codes are much smaller and more packed together to reflect this. Whereas in the north, the zip codes are much larger because there is less of a population in this area. For this reason, the black dots indicating the presence of practices with height adjustable exam tables are much more concentrated in the southern portion of the map and much more spread out in the top half. The northern section of the map is predominantly yellow and orange, but if you notice, there is one very large red zip code in the center of the map. It's notable that this zip code has 0 practices with exam tables in it, and if you look in the zip codes of the surrounding area, they also have low numbers of practices with exam tables. This is concerning for this particular zip code, given that there is a high population of people with a mobility impairment and very little access to potentially needed equipment in that zip code and the surrounding zip codes. And this would suggest that someone who needs that equipment would have to travel very far to get the care that they would need. The southern portion of the map is more mixed in color, and there's a larger concentration of red zip codes in the bottom center of the map. You can see that there are more practices with exam tables in the southern region, but again, the majority of the zip codes have either 0 or 1 practices with exam tables. All right, and we can move to the next slide. So moving on to our second map, this one is displaying the number of practices per zip code that have accessible scales. So as you can see, this map is very similar to the first. It's still a map of LA County, and it has the same coloring as the first map. We're using the yellow, orange, and red coloring scale. However, on this map, the black dots are indicating the number of practices that contain accessible scales instead of accessible exam tables. The number of practices per zip code still ranges from 0 to 10, but you can notice that there are even more zeros and lower numbers on this map. On this map, there are 133 zip codes that have 0 practices with accessible scales. Again, there's only one zip code that has 10 practices with accessible scales, and it's an orange zip code located in the densely populated region of the county near the center. Though it's great that this zip code has many practices with accessible scales, it's interesting that in the northern region of the map, the majority of the zip codes have 0 practices with scales, despite there still being that giant red zip code in the middle of the map. Again, this is concerning because an individual with a mobility impairment in that region would likely have to travel a great distance in order to find this equipment if they needed it, or they would just have to accept subpar healthcare. All right, we can move to the next one. So this slide is showing the last of our 3 maps. This one is displaying the number of practices with patient lifts. Again, this map is very similar to the first two and contains the same zip code coloring, but you can notice that the range of practices per zip code containing lifts on this map is even lower. So this ranges from 0 to 6 practices in the zip codes. It's clear that there are many more zeros and ones on this map. There are actually 174 zip codes with 0 practices with a patient lift, and only 1 zip code has 6 practices. And again, it's an orange zip code. This one is located in the central portion of the county. Again, the large red zip code in the center of the map has 0 patient lifts, and of the northern zip codes, only 2 to 3 of those zip codes have a number other than 0, which again highlights the point that for people in this region that may need specialized equipment, they would likely have to travel pretty far in order to get it. All right, we can move to the next slide. All right, so this slide is showing an additional map of LA County, but you can see that the coloring is very different from the previous maps and that there are no black dots indicating the presence of specialized equipment. Only 4 zip codes are colored on this map, and these 4 are our zip code highlights. So we're gonna dive a little deeper into each of these zip codes in the coming slides. The first highlighted zip code is zip code 93550, which is Palmdale, California. And it is the large red zip code in the upper middle section of the map that we've pointed out a couple times. The second zip code is 91767, North Pomona, California. It's an orange zip code on the far right lower portion of the map. The third zip code, 90007, is Los Angeles City, California. It's also an orange zip code located in the lower middle section of the map. And last, the 90201 Bell Gardens, California zip code is a red zip code located in the middle lower portion of the map. So we selected these 4 zip codes for highlights based on them having unique characteristics such as a presence or a lack thereof of practices with accessible equipment, the high poverty rate or racial or ethnic characteristics of that particular zip code. So beyond the geographic distribution of the practices with accessible equipment, we were concerned that distance might not be the only issue of concern, and that poverty, income, race, or ethnicity might also be influencing factors for the disparities in equipment. All of the poverty, race, and ethnicity information depicted in the next 4 slides is drawn from the 2016 Census Bureau data. Again, we chose 2016 data for consistency's sake, given that the audit and mobility impairment data used in the maps was also from 2016. All right, we can move to the next slide. All right, so this slide is showing the information from the first of our 4 zip code highlights. This is zip code 93550, Palmdale, California. If you remember, this is the very large red zip code in the center of the map. We selected this zip code because it has a very high population density of people with mobility impairments and a lack of practices with accessible equipment. We also found it interesting because of its high poverty rate and ethnic makeup. This zip code has a total population of roughly 75,000 people, with 4,855 or 7.2% of the people in this zip code reporting a mobility impairment. This zip code has a median household income of $38,000 and a poverty rate of 32.3%. On this slide, there's a basic chart with the first row showing the number of practices with equipment within this zip code, showing that there aren't any practices in this zip code that have an exam table, a lift, or a scale. For this zip code, the second row of the chart isn't applicable since there are no practices with equipment in the zip code. Given that there aren't any practices with accessible equipment in this zip code, the 4,855 people reporting a mobility impairment would have to seek care outside of this zip code if they needed accessible equipment, though we recognize that mobility impairment is a very broad term, and that simply because someone indicated the presence of a mobility impairment doesn't mean that they would necessarily need this equipment. There's also a pie chart on this slide indicating the racial and ethnic makeup of this zip code. The pie chart shows that the racial makeup of the zip code is predominantly Hispanic at roughly 65%, followed by white at 16%, and Black or African American at roughly 13%. And the remaining of the racial and ethnic group make up less than 10% of the population. So as you can see, this zip code is highly concerning given the numerous vulnerability factors of its population, including the fact that the population is predominantly made up of minorities, the high population density of people with mobility impairments, the high poverty rate, and the fact that there are no practices within this zip code to have accessible equipment. The location of the zip code is also of concern given that it's in the northern, more spread out region of the county, which would mean that people would have to travel pretty far in order to find some equipment. All right, we can move to the next slide. So this slide is showing the second of the highlighted zip codes, 90201, Bell Gardens, California, which is the other red zip code that is located in the southern central portion of the county. We selected this zip code because we found it interesting that despite the similarities between this zip code and the previous zip code that we talked about, Palmdale, it's very similar in terms of population density of impairment and racial and income factors, but this zip code is a lot more accessible. So this slide has the same layout as the previous slide, with the table indicating the presence of practices with equipment in the zip code and the pie chart indicating racial and ethnic breakdown of the zip code. This zip code has a total population of 101,000 and 4,228, 4.5% of people report a mobility impairment. The median household income of this zip code is roughly 37,000 with a poverty rate of 28.2%. The equipment table shows that there are 6 providers with exam tables, 1 provider with a lift, and 5 providers with scales. The second row of the table is going off of the assumption that each of the 4,228 people with a mobility impairment in this zip code need specialized equipment. We recognize that this is likely not the case. However, we wanted to show the disparities between the need and the presence of equipment. This second row shows that each of the 6 practices with an exam table would have to see 704 people with a mobility impairment. It also shows that of the 4,228 people with a mobility impairment in this zip code, all of them that need a lift would have to go to the same practice, and that the 5 practices with scales would each have to see 845 people. The racial and ethnic breakdown of the zip code shows that 95% of the people are Hispanic, and that all of the remaining ethnic groups make up less than 10% of the population. As previously mentioned, this zip code is similar in some characteristics to Palmdale, California. However, it's located in the more densely populated area of LA County, and the poverty rate is slightly lower. So there's the potential that these 2 factors might play a part in the increased presence of practices with accessible equipment. And we can move on to the next slide. All right, so this slide is showing the third of the highlighted zip codes. It's 91767, North Pomona, California. As a reminder, this zip code is the orange zip code located in the far east and southern portion of the county. We found this zip code to be interesting because it is lower needs in terms of the number of people with a mobility impairment, and yet it has more practices with accessible equipment. This zip code has a population of roughly 48,000, and 2,924, or 6.4% of these people indicate having a mobility impairment. The median household income of this zip code is 49,000, roughly 50,000, with a poverty rate of 20.5%. The equipment table on this slide shows that there are 10 providers with exam tables, 4 providers with lifts, and 4 providers with scales. Again, the second row is based on the assumption that all the people who reported an impairment would need this equipment, again recognizing that this is likely not the actual case. However, this would indicate that the 10 providers with exam tables would each have to see 292 people, and the 4 providers with lifts and scales would each have to see 731 patients. Again, the racial and ethnic makeup of this zip code is predominantly Hispanic at 66%, with 16% being white and roughly 9% being Black or African American. And the remaining ethnic groups make up less than 10% of the population. As you can see, this zip code is still very racially diverse, but the median income is much higher than the previous zip codes, and the poverty rate is lower. This is interesting because despite there being a lower population density of people with a mobility impairment or less of a need, there are more practices with accessible equipment, potentially pointing to a relationship between income and accessibility. All right, we can go to the next slide. All right, so this slide is showing the last of our 4 highlighted zip codes. This is zip code 90007, and this is Los Angeles, California. As a reminder, this is the other orange zip code that's located in the southwestern portion of the county. We selected this zip code because of its extremely high poverty rate, which we will get to. The zip code has a total population of 40,920, with 2,028 people, or 5%, indicating a mobility impairment. The median income of this zip code is $22,420 with a poverty rate of 48.5%. The equipment chart here shows that there are 2 providers with exam tables in this zip code, no providers with lifts, and 1 provider with a scale. Again, assuming that all 2,000 people would need this equipment, this would mean that 1,014 people would have to be seen by each of the 2 providers with exam tables, and that all 2,028 people with a mobility impairment in the zip code would need to go to the same provider if they need a scale. It also shows that those who might need a lift in this zip code would have to go outside of their zip code to find a provider that might have that equipment. The racial breakdown of this zip code shows that 52% of the population is Hispanic, 18% is Asian, and 17% is white, 10% is Black or African American, and the remaining ethnic groups make up less than 10% of the population. This zip code is particularly interesting given the extremely high poverty rate and the increased racial diversity, though it is still predominantly Hispanic. This zip code is still more accessible than some of the others like Palmdale, that first zip code that we talked about, in terms of providers with equipment, but there still remains a disparity between the need and the level of equipment available. It should be noted that this zip code is the home of USC, University of Southern California, which may play a part in the high poverty rate, though the surrounding areas of the university are still very impoverished. We're not quite sure if the university's presence in this zip code influences the presence of accessible equipment within the zip code. And with that, I will turn the time back over to Dr. Mudrick.
All right, thank you. Next slide, please. So before talking about what's on this slide about key insights from mapping the accessible offices, I want to point out some caveats with the data and analysis. First, the audit instrument that the accessibility data is based on was not designed with research explicitly in mind. And so there is some unclear wording for some of the questions, and that can affect the data quality. Second, the data collection process is done separately by each of the managed care plans. So because it's not overseen by a single entity, there are some questions about the consistency in the data collection process. Third, the data are from the primary care physician practices associated with the 2 managed care plans, but they do not represent all primary care practices in California, in LA County, I should say. They only represent the LA County practices that are associated with the 2 managed care plans. Finally, we have only limited information on the characteristics of the practice. We have their zip code and county and their characteristics. And so with this limited information, we're sort of limited in what we conclude about the patients that are seen in these practices and the characteristics of the practices themselves, like how are they group practices, are they single doctor practices, and so forth. So those are a few caveats with the data, but let me talk next about some of the key insights from this analysis, especially with the maps, although I think Kieran has done a wonderful job teasing out the meaning of these. The northern part of LA County offers very few choices of accessible offices, even though the zip codes contain a number of people with mobility impairment. The distances here are large, and for someone urgently in need of an accessible setting, this is a real challenge to get to care. And the zip code detail indicates and strongly suggests that incomes are low, and that can also affect the ease of travel. Even where travel may be easier in the denser southern part of the county, many zip codes have no practices with accessible equipment. Choices of accessible providers are therefore limited. The number of people with mobility impairments per practice with accessible equipment also may impose some limits on a nearby choice. Even if the accessible medical practice is down the block from a patient may not be able to use that provider if that provider is not on the plan to which that particular patient has subscribed. So there's a little more than just where it is. Does it match with your plan? The zip code details suggest that it's important to ask whether accessible offices are also more likely to be present in higher income zip codes or in zip codes with a smaller presence of people of color. So I think the detail we've seen really continues to raise questions for us about disparities that cross disability and race and ethnicity. Mary Lou Breslin will now discuss how this analysis and the methodology fit into the larger health policy context. Turn it to you, Mary Lou.
Okay, well, thank you both Nancy and Kieran. So let's go to the next slide, please. So in part 3, I would like to talk briefly about how measuring access in medical offices is starting to be reflected in broader healthcare initiatives and policy, and what some of the opportunities for using the data we have so far to advance policies that could improve healthcare for people with disabilities. The next slide, please. So what's happening across the U.S.? We've been seeing some really important changes in the way federal agencies are viewing their role in measuring accessibility of healthcare facilities. In particular, we've been seeing very significant work coming out of CMS, and that is only appropriate in that both HHS and CMS are responsible for an enormous amount of healthcare services provided to everyone in the country. While these changes haven't been really promoted yet, a ground shift in data collection, such as we've been describing so far today, they still signal a trend in the right direction, and they present some very important advocacy opportunities for the future. We've also been seeing the evolution of partnerships between Medicaid managed care organizations and disability organizations that are aimed at improving accessibility of provider facilities and services. Obviously, too, as many of you know, academic institutions are researching and publishing more studies on the effect of barriers to care and health outcomes and the role that accessibility or lack of it play in promoting or preventing good health outcomes and equitable care. Of course, legal advocacy continues using the ADA and Section 504 of the 1973 Rehab Act. Next slide, please. So let's just take a quick look chronologically at some of the progress we've been seeing. As most of you know, hospital system access litigation has been going on for 20 years or more, beginning with one of the larger cases, which was the case involving Kaiser Permanente in the early 2000s. Private firms and attorneys have brought many more cases as well. And the Department of Justice's Barrier-Free Healthcare Initiative has resulted in many settlements, particularly involving auxiliary aids and services within larger healthcare provider systems and networks. Thanks to community advocacy, and this is again is a nod both to June Kales and Brenda Primo, in 2012, the California Department of Healthcare Services extended the physical access audit that we've been talking about today to specialty and ancillary service providers with an emphasis on high volume providers. The audit that is being used for specialty and ancillary service providers includes some additional questions on certain kinds of equipment, including mammography machines, for example. And as Nancy and Kieran mentioned, the results of the study we've been talking about earlier applied only to primary care offices. At the federal agency level in 2015, the Office of Minority Health within HHS CMS released an important equity plan for improving quality of Medicare that included a statement calling for an increase in physical accessibility of healthcare facilities. The plan focused on 6 priority areas and aimed to reduce health disparities among vulnerable populations, including racial and ethnic groups, the LGBT community, and really for the first time, people with disabilities. It's a little interesting in that the fact that this happened so far into the current century, even though the ADA and 504 occurred decades earlier. While it might seem obvious that departments within HHS would recognize that healthcare facilities are not fully accessible, especially in light of the agency's regulatory authority under Section 504 and the ADA, perhaps more importantly, the equity plan actually, in our view, signaled for the first time that HHS, and specifically the Office of Minority Health within CMS, recognized that disability is a bona fide population health disparity demographic, and that people with disabilities experience significant barriers to health and healthcare that are deserving of attention. And also, for the first time, accessibility was included at the same level of importance with the other 5 priority areas, including, this is with respect again to Medicare, including expanding the collection, reporting, and analysis of standardized data, and developing and disseminating promising approaches to reducing health disparities. 2016 was a big year. In 2016, again, the CMS Office of Minority Health also commissioned a study examining the intersection of race, ethnicity, and disability, further signaling that it had fully embraced disability as a disparities population. Again, in 2016, HHS CMS released sweeping new Medicaid managed care final rules, and they included a final rule that provided a framework for scaling up data collection efforts currently underway in the small number of states, some of which we've been discussing today. This is in regard to accessibility of healthcare providers for people with disabilities. The rule requires that Medicaid managed care plans provider directories include information on the accessibility of network provider offices and facilities. The rule also directs states to develop and enforce network adequacy standards that consider the ability of network providers to ensure physical access, reasonable accommodation, culturally competent communications, and accessible equipment for Medicaid enrollees with physical or mental disabilities. And the rule lastly requires that states ensure that managed care organizations, prepaid inpatient health plans and prepaid ambulatory health plans comply with their contract requirement to ensure that network providers provide physical access, accommodations, and accessible equipment for Medicaid enrollees with physical or mental disabilities. Of course, the caveat is that with the change of administration, this rule was, for all practical purposes, shelved, even though it wasn't fully withdrawn. And HHS signaled to the governors in every state that they would be willing to work with them to find ways to not implement the parts of the rules that the governors thought might be administrative burdens while the administration worked on revising these regulations. The reason we mention these Medicaid managed care rules is because this was an attempt by the agencies to put forward very, very strong and important and really new language that would have applied to all the Medicaid managed care organizations and held out a lot of hope and opportunity to be able to sort of move the needle on accessibility. We hope that at some point in the future, the content of this rule can be revisited in a serious, substantive way and can be used effectively for advocacy to increase accessibility. Next slide, please. So again, within CMS, the Medicare-Medicaid Coordination Office, this is sometimes called the Duals Office, this was created under the Affordable Care Act, created a disability competent care self-assessment tool that was released in 2017. The tool was posted to a website called Resources for Integrated Care that offers technical assistance products and webinars to help both providers and health plans in coordinating care for dually eligible beneficiaries. That's people who have both Medicare and Medicaid. The Pillar 3 of the self-assessment tool focuses on access and relates to understanding and addressing barriers to care, including physical barriers. This Duals Office has been really entrepreneurial in its work to try to advance the issue of accessibility in healthcare. So this is one of the manifestations of that advocacy. Also in 2017, CMS released an issue brief entitled Increasing the Physical Accessibility of Healthcare Facilities, and that provides detailed information about steps that providers can take to remove barriers to care. I think one of the actually more interesting efforts by CMS was the agency's attempt to spur managed care health plans into collecting accessibility data on their provider networks using the three-way contracts between CMS, the state, and the health plans that serve dually eligible beneficiaries. This is sort of corollary to the intent of the 2016 managed care rule. These contracts were held to a very high standard, requiring a detailed explanation of accessibility of the plan's provider network. And CMS required that the contracts explain its mechanisms for conducting on-site accessibility reviews, and in some cases, use of specific survey tools and designation of a responsible person to carry out the surveys, policy modifications, auxiliary aids and services, and more. While all of these actions are required, of course, by the ADA, they're seldom set out in such detail in contract language. And generally, these contracts include a provision requiring that the parties attest to complying with the ADA with little or no guidance about how to do so. And while it's unclear how serious the plans took these contract requirements, and we know that that's, of course, the devil is in the implementation details. I think what's important is that CMS understood and attempted to move forward on the issue of accessibility by being clear that the extent to which barriers to care needed to be evaluated and removed, and presented quite detailed guidance about how to evaluate the network participants. At some point in the future, we hope that this model can be revisited along with development of some implementation tools that would assist states and plans to really conduct meaningful work on the issue. Next slide, please. So in addition to federal agency actions, we're also seeing partnerships between managed care health plans and disability advocates. For example, Centene Health Plan has established a partnership with the National Council on Independent Living. Centene is requiring providers in some of its markets to self-report accessibility using a California audit tool we've been talking about today. While this model relies on attestation by the providers, what they report is being verified by local independent living centers. And providers who wish to remove an identified barrier can apply for a grant from Centene's Barrier Removal Fund. And as of 2018, 52 healthcare providers, including primary care, OBGYN, and mental health providers across Illinois, Texas, and Ohio, received a total of $470,000 in grants to remove both physical and programmatic barriers. Centene received CMS's Health Equity Award for this work, which is also an indicator that CMS is appreciating the fact that accessibility remains a problem and that there are still significant barriers out there, and work that's being done to try to remove these barriers is valued and needs to be acknowledged. Centene rolled out the same program in 2019 in Florida, Kansas, and New Mexico. Continuing its leadership role, the CMS Office of Minority Health also launched initiatives, one specifically aimed at improving access to care for people with disabilities in 2020. And this one involves videos, a patient guide, and resources inventory. Next slide, please. So the work that California has done to initiate and systematize collection of accessibility data for primary care physicians, and more recently for specialty and ancillary providers, suggests a model that could potentially be replicated in other states and even nationally, as long as certain types of healthcare conditions, as long as certain types of healthcare continues to be delivered in the offices of physicians. We need to know more about accessibility of those physician facilities, and we need to find effective ways of incentivizing removal of barriers and purchase of accessible examination equipment. A beginning step would be to create a national audit instrument, as Nancy referred to earlier, perhaps based on a California tool or perhaps based on another tool, but which is tested and validated that plans are required to use. CMS took some important steps in suggesting that plans be required to use a tool. They didn't go so far as to specify a particular tool in most cases. The Medicaid managed care plans themselves are really quite well positioned to assume a more proactive role in determining provider network accessibility and availability of accessible equipment. In California, some have incentivized access modifications and even provided accessible equipment for high volume providers. This model has been shown to be effective and needs to be replicated, in our view. Teaming with local advocacy organizations has proven effective as well in terms of identifying barriers, recommending solutions, and providing staff training. While several federal initiatives have required managed care plans to publish access information in provider directories, as we mentioned earlier, this information is often inconsistent and more often it's missing altogether. So increasing availability of this information in directories would be an important step in helping people with disabilities determine the level of accessibility of the providers in their networks. Next slide, please. So I just would just like to end with a very quick summary of the main points we've touched on in the webinar today. Number one, it is possible to audit a large number of primary care offices. The California method has worked and it's replicable. Number two, audits produce information that we know are useful both to providers and to patients, and they're useful from a research standpoint, as we've shown today. Number three, a geographic look can help target priorities for action. I think that the material that Kirian presented shows that this is a valid way to understand the impact of the limited amount of accessible equipment that's available, and it serves as an advocacy tool. Knowing the density of accessible care sites doesn't relieve every provider of ADA obligations. Patients also have to be able to choose their provider when that's feasible within the limitations of their health plan. And number five, CMS and other federal agencies have a role in monitoring, facilitating, and enforcing physical access to healthcare facilities. We've seen that they have begun to take up the mantle of that role. We need to work with them going forward and increase their oversight roles, because they were willing to take on some important new initiatives. We hope that those initiatives can be renewed and revisited soon in the future. And finally, attention to physical and programmatic accessibility of healthcare facilities is increasing with public and private efforts, but nevertheless, monitoring for progress is still necessary, as I think the work that we've been doing over the last, it's almost 15 years, in terms of monitoring what California has been doing shows. So that wraps it up for me. I'm going to turn it back over to Louis to see if we have any questions.
All right, thank you, Nancy, Mary Lou, Kirian. That was a great presentation. For everyone listening, this is the time to submit questions in the chat window, and we'll get to those in a moment. And I do want to mention that somebody did ask where they can find that video that Mary Lou sent or showed, and so that she put that in the chat room. So if you have a question about that, or if you have a question about where to find that, you can get that in the chat window. So let me ask one question before we get to the questions that are coming in. Are you, in terms of the research, do you have plans to expand this, to do other related work to this, or what's the future look on this?
This is Nancy. Mary Lou, you want to answer this? You want me to?
I would defer to you, and I may have one comment, but please go ahead.
All right. Well, so certainly one thing we want to do is we want to publish these data, publish these findings, and that's the next thing that we're going to work on. Another possibility that we haven't had a chance to explore. I mentioned briefly that we actually got a hold of the California plans data for the period 2006 to 2009. The format of the tool was a little different in that time period than they revised it for use in the starting in 2012. But we still have some data from the 2006 to 2009 period. And there are some practices that are represented both in the 2006 to 2009 period as well as the more recent period. So one additional analysis that is possible is to look at if there was change, how much change there was for these particular providers for whom we have data at 2 points in time. But what we know is the aggregate difference in how many, percentage of exam tables at these 2 points in time. But for any particular provider, we don't really know. And the 2 data sets have an overlap in particular practices, but they're not identical. We didn't get the 5 plans who sent us data most recently were not the same 5 plans that sent us data earlier. 3 of them were the same, but then 2 of them were different. So that's another analysis that we're interested in doing. And I think that the third thing that we've talked about is to really spend more time talking about these policy issues that Mary Lou has highlighted most recently and connect this work more concretely to what its policy implications are. And Mary Lou, I'll let you now.
I was just going to say that I think one of the challenges that we faced is collecting the data through the managed care health plans. They've been, the ones that have worked with us have been very gracious about their willingness to share the data with us. Their willingness to do so, I think, will affect our ability to continue either collecting newer data as we're going forward, or taking a look at the ancillary and specialty provider data, which I think we haven't looked at yet, and I think that that's something that we would like to do. That the requirement to collect that data has been in effect for 8 years, so there should be a fairly decent amount of information available now if the plans would be willing to share it with us. If they have it and can organize it and send it to us in a way that makes sense, and if they're willing to share it. So I would just say that we would probably be talking about whether that would be one of the next steps for us.
Okay, that's great. And I would just say, as a former resident of Los Angeles, having grown up in Los Angeles, I mean, I know exactly, and I think you guys hit it really perfectly, the difference between those northern counties and the southern and eastern counties, where basically Los Angeles County is kind of a microcosm of rural, suburban, and urban areas. And so those northern ones are really rural. And so in LA, as everybody knows, you do a lot by traveling by car, by public transportation to move around. So moving to different places or going to different providers is not surprising, and it may not be something close by. It'd be interesting to see if those providers, I know they're already doing the yeoman's effort for you, but it'd be great if they could provide some kind of patient population, just zip code statistics, so that you can sort of see where their patient load is coming from. That might map into it pretty well too. All right, let's take a question from the audience. Can you please tell us more about what the reviewer's training entails? Do reviewers typically have a background in architecture, facilities, healthcare, or something else?
Well, this is Mary Lou. I can take a shot at that. Let me just say that we were not involved in one of the key levels of training with the providers, but were involved with a sort of overarching training. So I could give you a little bit of a picture of what was done. When again, this is owed very significantly to both Brenda Primo and June Kales, who really are responsible for having worked with the plans to create an interest in surveying for accessibility, and who created the initial training modules that were used with the plans. But basically, for the primary care office audit, the plans sent out somebody from their staff. Often it was a nurse. I think more often than not, it was someone who had a nursing degree who was within the plan's employment purview. They received 2 levels of training, at least initially. One of them took place in like around 2011 or 2012, probably 2011, involving sort of an overview of what the issues are for people with disabilities and healthcare access. And my organization, DREDF, was involved with several other organizations, including Brenda and June and their affiliations, to offer this training. So this was a, sort of a overview of what the major key issues are and why the facility site review had included this additional audit requirement. Then their staff, some key staff within a couple of key health plans, sort of took over the larger training, and they would put together a number of people from a number of plans and go through the audit instrument itself, the tool, and explain what was expected of the site review when people actually landed on site at a physician's office. So they, this was really about sort of explaining how to use the tool, what it meant, to take certain kinds of measurements. Certain things were explained that might, have this kind of architectural aspect, so that they didn't feel that they couldn't handle the assignment to fill out the audit correctly. So there was this, initially there was this two levels of training. I can't speak to what they're doing right now. I'm sure that there's been staff turnover and changes in the audit process, but at least for the data that we're reporting on in this webinar, the folks who were trained up to collect it did have a pretty good overview of what was expected.
Okay, Nancy, were you going to add anything, or?
The only thing that I would add is that the training was, as Mary Lou said, a mix of making sure people understood what the issues were for people with disabilities, as well as how to use the tool. And one thing that I thought, I went and observed one of them, was the fact that they were training people together from different plans, so that they brought together folks from these different plans and did it in different settings. Like I watched one in LA County one time. And I thought that was actually very interesting, because it gave folks a chance to make sure that they were to some extent going to do the same thing, because they were being trained together in the same session and they heard each other's questions and so forth. One of the issues that comes when we try to publish the data from this analysis is, well, what's the inter-rater reliability in using this tool? And because this process was not envisioned as a research process, that we can't speak extremely strongly to that question, but the fact that they were across several plans training people together, I think increased the ability for there to be some better inter-rater reliability as a consequence of the joint training.
Okay. I also want to point out when Mary Lou at the end was talking about the CMS efforts and the Centene efforts, that Centene and Nickel actually did a webinar on our healthcare webinar series in October. So if you were interested in what they were doing, you may want to go back to our archive at adapresentations.org to listen to their presentation. And then CMS and Office of Minority Health will be making a presentation on our webinar series in September. So you can hear from them about what they have done, what they're doing now, and maybe what they're planning to do. I'm not sure. So that will be in September 24th. All right, well, you all will appreciate your all being here, and if you have any other questions or if something comes up to you as you are thinking about this going forward, you can contact, actually, can they contact you both? Do you have your contact information there? Maybe you can put your contact information in the chat window. Choose all.
Actually, I'm sorry, Liz, we should have said this earlier. Our contact information is on the last slide, and the previous two slides before the contact information includes a series of resources, and these are references and links to the material that we presented at the webinar. So I think it's all available.
Okay, good.
If you page back two slides to the first of the resources slide there. So at the top is a paper we published last year out of these data that provide more frequency distributions on the accessibility data in it. This is I think this is only LA County as well. Anyway, so, and this is an open access journal, so you can have access to that, which presents the data we've just talked about. And then, as Mary Lou said, these other links are to various documents that she's talked about in the course of the policy discussion.
Great, thank you. All right, so you can pick up these slides at the adapresentations.org today in the schedule section. By tomorrow, it'll be in the archive section. And Gabe, go ahead and go to their contact information, so if people want to contact them, they can. Or if you have other questions that are specifically about the ADA in relation to what maybe you've heard today, you can contact your regional ADA center at 1-800-949-4232. You're going to receive a link to an online session evaluation. Please complete that evaluation for today's program, as we really value your input and want to let our funder understand about the value of the presentations we've been putting on. We want to thank all of our speakers today for sharing the time and knowledge with us. And that was really a great presentation. And a reminder to all of you listening that the session is recorded and it will be available for viewing next week at adapresentations.org in the archive section of healthcare. Our next webinar will be on July 23rd, and we'll be joined by Jan Garrett of the Pacific ADA Center and Emily Schumann of the Rocky Mountain ADA Center for a presentation on specifics of physical access in healthcare and of the more detail of what was gone over here today. So we hope that you can join us. Watch your email 2 weeks ahead for the announcement of the opening of that registration. So thank you again, everyone, for attending. And thank you again, Mary Lou, Nancy, and Kirian for your time and a great presentation. It was really interesting. Have a good rest of your afternoon, everyone. Bye-bye.
Thank you.